concerning obstetrics and gynecology in the morning for about an hour or so. And whatever of interest I find, I download it and save it on my laptop, computer. I have also access to a few journals like British Journal of Obstetrics and Gynecology and a few other journals also, like the obstetrician and gynecologist TOG, and in addition to that, there are certain sites which suggest to you something which is happening now and which is latest. So I keep collecting all those things. Yesterday, a colleague of mine asked that did I have anything on ciprofloxacin use in pregnancy, in early pregnancy. Now, I vaguely remembered that I had it on my computer and I found it quite immediately. Now, ciprofloxacin in pregnancy, generally we do not use. But that study was, it was a Danish study, and that showed that it does not cause miscarriage, and the incidence of major malformations also, even given in early stages, does not result in increased incidence of malformations, even if used in first trimester. Now, the relevance of that, why I am telling you that, not that you should use ciprofloxacin without any indication, but what I want to highlight one particular thing, that in that Danish study, what they did was that they collected data were collected in the period between 97 to 2016 and included all registers. This is Danish history. In Denmark and Scandinavian countries, they have meticulous record of all pregnancies, their outcomes, whatever happens with that, detail of all that. So it is easy for them to go back and find out the record of whatever period they want, and whatever parameters they want to measure, they can, because those are reliable records. And in that, during that period, included all registered pregnancies that ended in an elective termination, miscarriage, stillbirth, or a live birth. So all kinds of things. Exposure was defined as deeming one or more prescription of ciprofloxacin. So they dug out all that and found out that what number of patients at what stages of pregnancies they had ciprofloxacin. And then they found out, and then the conclusion were drawn. From that study, I thought that I'll make to all of you a suggestion, those who are sitting here and those who would be listening, that whatever you do, you should have a logbook with you, a personal logbook, not necessarily that CPSP logbook. And that is not for meeting a formality. That is your personal, precious logbook, in which all that you do during the day, clinically, you record that. And if you perform or assist or even observe a procedure or something that happened or a delivery, then you record its details. For example, yesterday, I conducted 2 deliveries. In one, and those were straightforward deliveries. The first one, which happened quite straightforward, primi gravida, Rabia was assisting me. That happened without any forceps, without anything, spontaneous delivery. And immediately when I started suturing the episiotomy, I came across excessive bleeding. And initially I thought it was a little bit of uterine relaxation. We gave Syntocinon, etc. So we went through that drill. We put in a balloon and we also held the cervix with sponge holding forceps and all that. And we spent a good part of 1 hour with the patient, during which she must have lost about 1 liter of blood, not more than that, because she's now quite all right. But in that 1 hour, we had gone through those steps of managing postpartum hemorrhage. The cervix looked kind of unhealthy. It's a young patient, and that's why we would want to look at the cervix after purpurium after, say, 6 weeks and see how the cervix is. But the detail of that case adds to your experience, right? So you know that PPH can happen like this, and these are the things that you do. And when you are part of that, or even if you are observing, you make a note of that. That if there is PPH, you carry out massage of the uterus, you have a good look at the cervix and vaginal walls. If there are any tears, rule them out. And if you consider that it is atony of the uterus, you can give oxytocin, you give transamine, that's what we gave. And then in addition to massage, you then also prepare for balloon and do that procedure of putting in the balloon with condoms, etc. And also, if you find that the cervix is bleeding too heavily and there are no tears, then what we do is that we catch hold of the cervix at various points with sponge holding forceps, particularly laterally. And that generally pays. So that adds to your experience. And if you make a log of your daily work and you look at it after 1 month, you will find that you've seen quite a few cases. You assist at the cesarean section. You look at the lower segment, how thin it is, if it's a repeat cesarean or it is not. Sometimes it is a case of previous 3 cesarean sections, and the inside looks as if not even a single cesarean has been carried out. And sometimes you come across a patient in whom there was 1 cesarean section previously, and the lower segment is completely thinned out. And you can look at the history of the patient, what happened, where did the patient had her previous cesarean section, was it elective or was it in late labor or whatever. So from that, with each of those inputs, you have that experience. So it is important that you make a log of all that from today onwards. Today is 1st of February, you start doing it. You see, the purpose of this session, I now have come to realize, it is not only to help you pass the examination, that I'll give you a few tips, that this is the topic, this is the way that you answer. That is part of it, of course. Passing the examination is an important step, but that is not the end in itself. That is only a step for your professional progression, because it opens the doors for you to become as a specialist, that you can get a job which is commensurate with your experience and your qualification. So you can get a job of a senior registrar or an assistant professor, and then you build upon that experience as it is. But the important thing is that how much practically do you, and theoretically, of course, you know the subject. So in pursuit of passing that examination, what happens today is that I feel that most of the residents, most of the trainees, their only object seems to fulfill the prerequisites. You write a dissertation, you do so many cases, you assess so many cases, and you enter them and all that. Do you really learn from those cases that you are entering into your logbook and your electronic logbook or not? How much are you learning? Because when you are writing those, you are usually copying and pasting from one case to the other and all that, and making a few variations. And at that time, you are more concerned about putting in those variations or filling up the area, instead of really analyzing and looking at why it's happened like that. So my suggestion to you is that from that study, but if you have your own record, you will know what is happening. So it is, once again, this is a recurring theme that I keep talking about, that it is your individual responsibility to make yourself a good doctor in mannerism, in knowledge, and in your skills. So that's it. And part of that is that now these instruments do not really come in anywhere. That how do you hold an instrument? What is the purpose of an instrument? Why is it designed like that? And so on and so forth. And we just use it. So what is the rationale of using an instrument in a particular situation? Previously, we used to have a discussion, and when there was this face-to-face viva, so now we have talks in the examination, but then a tray would be laid out like this, as it is here today, and there would be an examiner who would either hand over an instrument and or ask that you pick up an instrument of your choice. And just the way that you picked up that instrument, that showed whether you had worked properly, whether you know the use of that, etc. So holding up of an instrument, for example, if they're obstetrical forceps, the way you hold it, the way you kind of disengage it or assemble the two blades, that would show how much knowledge you have and whether you have practically used it or not. So this is an important thing that I would want you to kind of register and practice. Now let us see. We can start with the minor procedure of a DNC. DNC is now being replaced by by not necessarily MVA, because by other procedures also. Previously, DNC used to be carried out for, say, incomplete abortion, for missed abortion or abortions, let's say one, for diagnostic purposes, like in cases of abnormal uterine bleeding, you want to do that, or polypectomy, etc. But now you have hysteroscopy or hysteroscopic assisted exploration or polypectomy or even biopsy. You have the facility of PIPEL, by which you would get a sample of the endometrium or endometrial cells. And for abortion related DNCs in less than 12 weeks, now MVA is there, or MVA should be carried out. So that is there. But essential basic knowledge of diagnostic DNC and the instruments which are used, that still is essential, because most of those instruments still hold importance and they are utilized even in these variations of the procedure in itself. So can someone tell me what are the steps for DNC? How would you say that these are the steps of the DNC? Bolo koi? Sanatam bolo.
So after assessment of the patient, after proper history examination and
yes, proper history and examination and
investigation, then fulfilling the prerequisites and ruling out any contraindications to the procedure, we will then
yes, I would have started. This is a good way of starting it, that you take the history of the patient. You should know what it is about. Then you would ensure that there is an indication for the procedure, an indication. मुझे एक और मैं भूलना चाहूँ तो एक थोड़ा सा एक अलग से importance. We had a patient in the clinic who came and she presented with some period of amenorrhea. The history was that she was overdue, pregnancy test was positive, and she took Bricky, 2 tablets twice a day for 3 days on her own, but she was still bleeding, continued to bleed. Obvious thing is that you carry out an ultrasound. So we carried out an ultrasound in the clinic, and we found that the uterus was empty. Its endometrial cavity was regular in outline, and there wasn't anything inside the uterus. So if there isn't anything inside the uterus, then hello, Hanji, Assalamualaikum. मैं आ जाता हूँ, मैंने अभी मैं क्लास ले रहा हूँ, उसके बाद मेरे 2 प्रोसीजर्स हैं, फिर मैं आ जाता हूँ. ठीक, मेरा इरादा था. हाँ ठीक है, ओके. So when we looked on the side of the uterus, there was a mass. What is the diagnosis? Ectopic, chronic ectopic. It had turned into chronic ectopic pregnancy. So she had taken that Bricky on her own and was continuing to bleed, and that Pfizer patient that we are going to do that. So history and correlation of those things, that is important. So in case of DNC indication, you make sure that there is indication, then you should know what is the proper position. Now, from the experience of, again, yesterday's deliveries, all of you need to know how to put the patient in lithotomy position. That is quite basic. I mean, if we are doing delivery in a lithotomy position in Hamid Latif Hospital, and if the poles are unequal, they are, and the patient is kind of sideways, that is not on. And that is everyone's responsibility. That's the responsibility of the consultant as well. What may happen to the patient? She may have some neurological problems because of that inappropriate position. So you should know how things work, how the table works, how the lithotomy poles are placed, what should be the height of the lithotomy pole, what should be the position of the resting pads on which the knees rest, because that's all important. And many of those patients who are under the influence of epidural, they at that time cannot protest because they are numb downwards. So they don't know how those movements of the legs are being carried out. And therefore, it is important that all of us, and before the patient is put in lithotomy position, make sure that the poles are at proper height and in proper place, width-wise, according to the patient's stature, her height, her weight, etc. And only after having adjusted those, then you put the patient in lithotomy position. So it is the responsibility of the assisting nurses or midwives. It is the responsibility of the resident. It is responsibility of the doctor. That all that ought to be appropriate for the procedure as well as appropriate for the patient's comfort. So it is important. So all those steps, like in DNC, you would put the patient in lithotomy position. Saying that is not enough. Making sure that the position is made properly and it will not, or it is least likely to result in any kind of residual damage. So that is your responsibility in future. Do look at it.
The preparation of cervix and lithotomy se pehle. Cytotech.
Right.
वो साइटोटेक ये नई चीज आ गई है, साइटोटेक नहीं है प्रेपरेशन, वो तो पहले आपने अगर दे दिया तो वो प्री ऑफ प्रेपरेशन में आती है, वो हम तो आप प्रोसीजर के साथ, अब प्रोसीजर के साथ तुम ठीक है कि वो सारी अगर इतनी डिटेल भी ना आ जाए कि वो जब तक प्रोसीजर तक पहुंचे वो बेल बज जाए और तुम्हारा टाइम खत्म हो जाए, वो वाली नहीं। वो ठीक है कि आप जब आप अब ये आप कह सकते हो कि जी I'll make sure that there is a proper indication and the patient is fed for anesthesia, and then with all that preparation फिर आप वो उसको proceeding with the procedure is that the patient is placed in the lithotomy position, because whenever you describe a procedure उसमें एक चीज आती है, पहले तो आती है preliminary workup, that you'll ensure that preliminary work, essential preliminary workup is carried out and has been carried out, and she is fit for the procedure. There is no contraindication. That this statement takes care of all that. And then in the operating theater, after she has been anesthetized, she is placed in lithotomy position. अब वो उसका तो साथ में मैंने बता दिया कि कैसे. After having placed in lithotomy position, then you prepare the area with solution. अब वो सोल्यूशन की स्ट्रेंथ क्या होगी, लिखो और मुझे बताना है कि कौन सा सोल्यूशन क्या क्या इस्तेमाल कर सकते हो। एक इनकम्प्लीट अबॉर्शन की आपने एमवीए करना है और उसके लिए कौन सा आप एंटीसेप्टिक इस्तेमाल करोगे प्रिपेयर करने के लिए, 1। और उसके बाद फिर देन यू ड्रेप द पेशेंट आफ्टर हैविंग डन दैट, और उससे पहले आपने जाहिर है गाउनिंग एंड ग्लविंग आपकी अपनी, आपको ग्लव्स पहनने आने चाहिए, गाउन पहनना चाहिए वगैरह वगैरह, वो कर दिए। When the patient is draped, then what do you do? First step of the procedure?
Empty the bladder.
नहीं पहले
Cover और drape हो गया, हाँ, EUA, examination under anesthesia. You must know what is the place of the uterus, what is the position of the uterus, what is the size of the uterus. So you get an impression, anteverted, retroverted, etc. or what. चलो मैं इसको जरा कन्वर्ट कर रहा हूँ डायग्नोस्टिक डीएनसी में, क्योंकि हम उस पे आते हैं। डायग्नोस्टिक डीएनसी जिस वक्त आज से 40 साल पहले डायग्नोस्टिक डीएनसी की जाती थी इवन इन असेसमेंट ऑफ इनफर्टिलिटी, जब अल्ट्रासाउंड आम नहीं हुआ था एंड वी वुडंट नो कि क्या ओवुलेशन हो रही है कि नहीं हो रही, हार्मोन एसिड्स भी नहीं अवेलेबल थे। अब जैसे साइकिल 21 पे आप प्रोजेस्टेरॉन करवा लेते हो, अब आप अल्ट्रासाउंड करवा के देख लेते हो कि फॉलिकल्स हैं कि नहीं है। तो उस वक्त प्री मेंस्ट्रुअल पीरियड में डीएनसी की जाती थी एंडोमेट्रियम लेने के लिए, उसकी हिस्टोलॉजिकल एग्जामिनेशन देखने के लिए कि वेदर इट इज सिक्रीटरी एंडोमेट्रियम और नॉट। वो सिक्रीटरी एंडोमेट्रियम होती थी तो दैट वुड मीन दैट द पेशेंट वाज ओव्यूलेटिंग। सो वो जो डायग्नोस्टिक डीएनसी आती थी उसमें ये इनफर्टिलिटी वाली जो चीज थी ये भी उसमें शामिल हुआ करती थी, विच इज टोटली अननेसेसरी। नाउ देयर आर नॉन इन्वेसिव मेथड्स ऑफ डूइंग ऑल दैट। सो मैं डायग्नोस्टिक डीएनसी की बात कर रहा हूँ। उसकी वजह यह है कि मैं आई वांट टू टेल यू अबाउट यूजिंग द यूट्राइन साउंड। In case of incomplete abortion, you don't use sound. Why not? Yes, because sound is a comparatively thinner instrument. It's a finer instrument, and you can very easily perforate the uterus, particularly if one is not properly careful. So, अच्छा, अब आगे आपने EUA कर लिया, फर्स्ट स्टेप उसमें हो गया। उसके बाद EUA करके आपने सिम्स स्पेकुलम, दिस स्पेकुलम इज नोन एज सिम्स। अगर ये एक है तो ये होगा वन सिंगल ब्लेड, और अगर वो दोनों साइड्स पे है तो डबल एंडेड सिम्स। वो डबल एंडेड हो जाएगा, ये सिंगल ब्लेड। तो you pass it, and you pass it in the cervix like this, into the so not cervix, in the you separate the labia and pass it like this, not like this, not like this, rather this, because the vaginal walls or vaginal canal is an anterior vaginal wall and a posterior vaginal wall. It is kind of flattish horizontally. It is not a vertical canal, it is mostly horizontal. And therefore you pass it in, although the introitus or labia are a kind of vertical in shape. But when you separate the labia, the introitus is roundish, and then you place it along the posterior vaginal wall. Even in an unanesthetized patient, if you are carrying out a speculum examination, pass it close to the fourchette, which is the posterior part of the introitus, and pass the blade along the posterior vaginal wall. That is the least sensitive and the least uncomfortable part of the lower genital tract. If you have a cuscus speculum, in that also is actually meant to be used in lithotomy position, the usual one that we use, because if you have the handles of that cuscus speculum anteriorly, they'll hit against the vestibule. Vestibule is the anterior part where the urethral opening is, and that's the most sensitive area. So that shouldn't be used like that. But in most of the cases, in dorsal position, in normal couch, we use it in other position. Whereas the handles or the handles of the cuscus speculum are placed anteriorly. That's not the absolutely correct position, but that's usually. So you pass in the Sims speculum and retract the posterior vaginal wall. And that will, in most of the instances, by this, you will be able to see or visualize the cervix. So when you look at the cervix, first you look at the vaginal walls, what they look like. Then you look at the cervix and you make a mental note of the cervical appearance. It is nulliparous, it is multiparous, it is thick, it is hypertrophic looking, it has some features of chronic cervicitis, etc. So those are the features that you will make a mental note of about the cervix. And after that, then you can, of course, उसमें हमने ये catheterization वगैरह सारा पहले हो गया. So you catch hold of the anterior lip of the cervix with a Valsalem forceps. This is the Valsalem forceps, and it should be used like this with the concavity upwards, so that if you have to pull it a little or apply traction a little bit, it will not hit against the vestibular area, because if you hold it like this, then it will hit against the vestibular area and would be uncomfortable. But it is applied only to hold the cervix and apply gentle traction. It is not applied to pull the cervix. Remember that, not pull the cervix, apply gentle traction. Essentially, to just stabilize the cervix in that particular position. So semspeculum, and then you hold the semspeculum, then should be held by the assistant, and the surgeon should hold the valsellum, right? Because then you can apply that particular traction or stability, because you need that stability for the uterus for the rest of the procedure. After you have done that, now since you have done that examination under anesthesia, you have a good impression of the size of the uterus and also of the direction of the uterus, whether it is anteverted or it is retroverted. And then you would pass a uterine sound. So you are holding the cervix with the valsellum forceps, and then you, in most of the cases, in 80-85% cases, it is anteverted uterus, and you ensure that it is like that. Then you hold this instrument in your fingertips. You don't hold it like this, because that will allow you to use unduly excessive force. So you hold it just in your fingertips like this, and holding the cervix, then you guide it into the cervical canal and in the direction of the uterine cavity. If it is anteriorly, you will pass it like this. If it is retroverted, then you will pass it like that. And remember that it is the only force that your fingertips can use it. So that would minimize or reduce the chance of perforation. Also, if you come across any undue resistance, then that again should be manipulated only with the fingertips, nothing more than that, right? So in most of the instances, you will get you passed it into the uterine cavity, and when you come across the resistance of the fundus, then you stop, and then while withdrawing, you place your finger over here, and then bring it out, and then you can see on this marked area how long this नहीं वो जब इस तरह से ऐसे किया ना, तो इसको विड्रॉ करने के लिए यहाँ पे फिंगर इस तरह से करके ऐसे कर लोगे, तो आपको पता है कि कहाँ पे आपकी फिंगर है, तो उससे आप देख सकते हो कि 10 सेंटीमीटर है। नहीं सर्विक्स में पगड़ी ना, तो ज्यादा तो तुमने यूट्रस की लेंथ देखनी है, पगड़ी बात है तो वो कर लिया। Now, this also is, this is the uterine sound and also the first dilator. Remember, because when it passes, it gives you that impression, because it is about 3 millimeters, 2 to 3 millimeters. So it is also is the first dilator. उसके बाद आप उसको ये है जो next dilator, thinnest dilator होगा, then ये उस ऐसे ही पकड़े रखना है उसको सर्विक्स को, और देन इसको होल्ड करने के दो तरीके हैं। डायलेटर को इसको होल्ड करने से भी पता चलता है कि क्या। अगेन द बेटर मेथड इज दैट यू होल्ड इट इन योर फिंगर टिप्स लाइक दिस, एंड देन यू पास इट into the cervix like this. The advantage of holding it like this is that the ulnar border of your hand that will touch against the buttock of the patient. When it touches against the buttock of the patient, then you cannot use the force of the arm. Now, if I am using it like this, the arm is being used, although I am holding it in my fingertips. But if it comes against the resistance, I can use only this force, right? So this is to prevent again accidental perforation of the uterine cavity by this. Or you hold it in this fashion with your finger at where what your estimate about the uterine cavity's length is, because you have measured it with the sound. So you place your finger over there, and then you pass it in, so that you cannot exceed that length, and you cannot push it further to into the uterine cavity to cause perforation. So either you hold it like this, or the better is that you hold it like this. मैं दोनों तरीके से कर लेता हूँ। अगर excessive resistance तो फिर मैं जरा इसको इस तरीके से निकाल. So you pass it like that, then you use the other end and make sure कि ये इधर उधर टच ना करे और दरमियान में से उसको पकड़ के उस तरीके से आप ले जाओ. And gradually you dilate the cervix to the required dilatation. Number 7. Number 7 Hagar's is, which is 7 millimeters. That is reasonably reasonable kind of dilatation, which will allow passage of a small sponge holding forceps. So after that dilatation, then so ये आ गया आपको Sims speculum, holding of the sound, uterine sound, and make sure that it is usually made of a malleable metal so that you can do it like this. You can modify it a little bit. You see, I have changed the curvature of the, and you can do it like that also. I mean, this is that is the characteristic, or this is the sound which has been made from a suitable metal for this purpose, for the sounds purpose, right? So dilatation is complete, and then the next step in a diagnostic DNC would be exploration of the uterine cavity for any polyp. Even if it has been reported on ultrasound these days, now previously it used to be standard practice that we didn't know if there was a polyp or not, but now we know that there would be. And so you pass in, we have various you know, these sizes of the ये कैसा है अजीब सा ये वो एक polyp forceps usually जो होती है उसमें वो होता है sponge forceps की तरह, but it doesn't has this ratchet. This is known as ratchet. ये जो इसका log click कर जाता है log ratchet, RATSHET ratchet. So वो ratchet जो है ये इसको लॉक कर लेता है एक किस्म का. तो जो ओवम फोर्सेप्स होती थी वो उसमें वो आप इस्तेमाल नहीं होती, वो इससे जरा रिंग इस तरह से होता था, बट देयर वाजंट एनीथिंग लाइक दैट.
खुद ही मैनुअली करना पड़ता है बोलते हैं.
तो ऐसे कर लिया ना, इसको ऐसे कर लो अगर ऐसे नहीं. हाँ. So and then what is important is that the direction in which you pass it in a flat direction, in a horizontal direction. If the uterus is like this, you pass it like this. And again, pass it in the direction from below a little upwards in the direction of the uterine cavity. Now, again, when you're holding the cervix with the valsellum and you apply gentle traction, it kind of straightens the uterine cavity also. But if sometimes you would find that the uterus is acutely anteverted, बहुत ही ऐसे आगे को है, and that you have to be a little careful. You have to apply a little bit of pulling surface and then gradually guide the sound or the dilator into that. And remember, the objective of passing dilator is to dilate the cervical canal, not the uterine cavity. So you don't have to go to the fundus. The rest of the things that I have told you that are only to prevent damage to the fundus by or perforation. And therefore, if you have come across that resistance at the internal os level, then you will only restrict manipulation only to that area, not more than that. So nothing more than that. Now, in holding the cervix like that, you pass in the sponge holding forceps in horizontal condition. It goes to the fundus. You will appreciate that. Then you open it, rotate it through 90 degrees, then close it. So if there is any growth like polyp, that will come in between, and then you close it, then bring it back to the horizontal position and then pull it out. So this is, you do this maneuver 2-3 times to see, and then afterwards, then you carry out the curettage. Now, there are various sizes of curettes. They're all laid out here. And usually, a curette would have a sharper side and a blunt side. Now, I personally think that if you are gentle, then sharper, I always use the sharper side. Then you, but the disadvantage is that if you are over enthusiastic with this, you can remove the basal layer of endometrium and cause Asherman syndrome. So, and particularly in cases of incomplete abortion, or what used to be called as septic abortion, if you use that, then it would really cause that Asherman syndrome thing. And then it was therefore advocated that you use only the rounded kind of end of this, not the sharper. But I still use sharper, again holding it like this, holding it with your fingertips, and then not like this. This is not the, or if you become a professor and you know how much force you are using it, then you can sometimes use it. But till you are a professor, you will use it like this, only like this. You can hold it like this if you are using or curating the anterior wall, then the lateral wall, and you do it in a systematic fashion, and only gently and gently, just the fingertips of the index finger and the other finger and the thumb. So you systematically from above downwards, and from interior left, posterior right, and then you bring it out, and all the curatings are then they are collected, and they or spread over a piece of gauze, and then you have make a visual inspection of the curatings, what they look like. They look like, and you now would be making comments about the amount of curatings, their look. They are scanty, they are moderate, exuberant, polypoidal curatings, or average amount of curatings, and normal looking tissue, or sometimes it is hemorrhagic areas. And if in cases of those missed abortions, sometimes you see that the embryonic tissue also, you can identify that, or there may be only kind of tissue which is kind of necrotic tissue. So you make a mental note, and you also write that in your notes, that that is the appearance of, and then you pick out those, and of course in case in those diagnostic things of mole. Remember that it could be if pregnancy related condition for which you are carrying out that procedure, then you should also be looking at the tissue from that point of view. And then you put that material that you get, 10% formalin solution. Remember that the indication for which you are doing that procedure is also important, in the sense that the curatings that you obtain sometimes are required to be placed also in some saline solution, for their analysis, which is other than, for example, if cytogenetic genetic analysis has to be carried out, or in those cases, it is not formalin that you would want the curatings or the tissue to be fixed in. So you place that in. But before doing that, when you are removing the instruments, after having removed the instruments, then swab the inside of the vagina to clear it of all the blood and other things that is there, and make sure that the external genitalia are also clean, and then applying a sterile pad over the vulva. Then the patient is drape is taken off, and the patient is put back in the lithotomy position. That is something which is the duty of the doctor, and most of the times you don't do it. You leave it to the nurses, right? Am I right?
Yes.
But that is the duty of the doctors. You should be doing it. You should be taking the drape off. You should be placing the pad on that, and then with the help of the nurse, make sure that the legs are brought together, and there is no problem in that. Not one by one, but both legs equally at the same time, and make sure that there is that part of the mattress over the table, so that the patient lies in even flat position, not that her back is a little high up and her feet are on the lower part, which will put extra strain to her lower back. So making sure that when the patient is brought down from the lithotomy to dorsal position, again, the table is even and the mattress is there. Until and unless that is made sure, don't bring the legs down. And this, if you would be doing yourself, you will be taking away so much of possibility of damage to the patient's nerves down from the lower back. Or if you are not doing it yourself because of something, then make sure that you are observing that and make sure that the persons who are doing it in the right position. So this is about some of these instruments, how they are held, how they are used, and what are the, and again, the other thing is that you should also know what are the pitfalls of using those. For example, some instruments are generally, which they wouldn't do anything wrong. I mean, placing in a sim speculum, you have to be very rough, and the condition has to be highly abnormal to cause any damage with this instrument, because it is placed to retract the posterior vaginal wall. Yes, with the valsellum, of course, when you are trying to hold that, you can, if you are rough, then you can cause a problem. You can it can, if you're pulling it too hard, it can cause tear of the cervical part, etc. Or with those instruments that you are introducing into the uterine cavity, including the sound, of course, you can cause a perforation of the uterus. So this is the approach with which you look at an instrument, you make use of it, and then be aware of its proper uses, its pitfalls, etc. So, and that would go on for all those others as well. Now, it's also important that how you hold the instrument. For example, this is the scissors. How you hold it. You don't hold it like this in index finger and thumb. If you do it, it's the most inefficient way of holding it, because you don't have any control over it. You cannot exert a lot of force, or not that you have to use, but not adequate amount of force, at least the ring finger. But the best would be if you use not ring finger, not the middle finger, ring finger, and these two fingers then provide a fulcrum. So it becomes more stable. If I have to cut something here, if I'm holding it here, then it's not that stable. Right? But if you are holding it like this, it would be more stable. So you can do it like this. And if you need to support, you place your finger here, but that should be out of the wound. If you are going to cut, say, a thread at assistance, you're making sure that it is like this, and the scissors should be cutting at the tip of the point. So that if you go a little further down, then you can damage some other part as well. So this is how you hold the scissors. And similarly, it's important that this is how you hold the needle holder also. Needle holder has to have a greater kind of, mobility. Not only the scissors, but this is something which needs, you have to manipulate the needle in tissues, sometimes from this angle, sometimes from this angle. So be familiar with the movements of your hands. You can pronate, supinate it. You can bring it like this. You can take it like this. And the best example is applying a cerclage in the cervix. So you take a bite from here, you take a bite from here, and when you go posteriorly, then you are at odds with the whole situation. What do you do with this? So you can do this, you can do this, etc. So you should be quite familiar of using a needle holder. This is a very good instrument to make you learn how you use such instruments, how you hold them, how you have a control on them, and how you manipulate them, how you use them. Although if this is a clamp, a vascular clamp that we use for pedicle clamp, as a matter of fact, not vascular. Pedicle clamp, which is the usual one. If it has teeth at the tips, then it is called a Cocker's forceps. This is a pedicle clamp, and again, you make a habit of using these instruments with the ring finger and the thumb, and with the two fingers providing it that fulcrum and that support, and which will help you hold the instrument with greater security. So this is that, and then these are important instruments. These are known as dissecting forceps. One is plain dissecting forceps, the other is tooth dissecting forceps. Tooth is used outside peritoneal cavity until and unless there is. So outside, Once the peritoneal cavity is open, then you don't use tooth forceps. Then you use only until and unless special circumstances you want to hold something and you ask for that. The nurse should not hand you over the tooth forceps. It is only the plain forceps that you utilize. So scissors, clamps, this, and similarly, artery forceps is a good instrument which can be used for many things. An artery forceps, don't say artery. I personally hate abbreviation. Artery, give me artery. Artery forceps, artery forceps. And a good nurse would hand you over if the surgeon just puts their hand like this, it means that the surgeon is asking for an artery forceps. And the job of the nurse, good nurse, is to slap this into the hand like this. So it comes into the hand like this, and you should be able to again use it with left and right hand equally to hold the. Now, this is an instrument which can be used to hold a bleeding point, an artery. It can be a small clamp also, a pedicle clamp also, and sometimes if nothing else is available, it can also be used as a needle hold. You just hold the needle in this and you stitch it up. You can hold this way or that way. So this is a very versatile instrument, the artery forceps. And what is its proper name? It's known as Spencer-Wells forceps. Spencer. So and there are those variations. Like I said, this is a pedicle clamp and then this is the Alice's tissue forceps. ALLIS apostrophe S. Alice's tissue forceps. Now it has teeth again. It comes in different lengths, small, large, etc. And you can hold even some soft, delicate tissues with this. Not the intestine, but others. For those intra-abdominal things that you need to hold sometimes, then there is no forceps Babcock, for example, when we hold. But we many a times hold the mesosalpinx with this. When you hold up the fallopian tube for ligation, you can hold this. But this it becomes a little traumatic. So Babcock isn't, but it is as the teeth, and this is a very useful instrument. Again, the way that you hold it is the same as goes for all these instruments, which open up and then close down like this. So this is for most of the instruments. In gynecology. We don't use many instruments with this. You have to be a little innovative. If there is one particular instrument which is not available, you sometimes make use of others. As I said, that in case of this artery forceps, this sometimes is quite handy for quite a few things. In addition to just only holding a bleeding point, it can be of use in many situations. So this is about it. We'll discuss the outlet forceps or others at some other time, right?
Thank you.
So thank you very much.
सर कुछ सवाल थे पॉलीपेक्टमी वाला रिपीट करने का कह रहे थे सर जो होल्डर से आपने किया था रोटेशन
indeed topic क्या है diagnostic ये D and C ना लिखा करें please. D, it is D and C, although if you have to write an N, you will have to put an apostrophe before this D and apostrophe and then N, then that would be an abbreviation for and. But it is D, because if you say D, dilatation and ureter, just N, I don't know what it means. Polypectomy, polypectomy is, yes, of course, you hold the cervix, and then you pass in the huh?
सर कैमरे में नजर नहीं आ रहा
Yeah.
सर यहाँ बैठ जाए और कैमरे में नजर को आप
अच्छा, कैमरे से This is uterus, and you take the after having dilated it adequately, you pass in you close it, you pass the sponge forceps or the ovum forceps inside the cervical canal, go to the top of the uterine cavity, and here you open it, and then you rotate it through 90 degrees. And if there is a growth that most likely will come in between the two blades, then you close it and rotate it back to that horizontal position and then pull it out. So you go through this motion 2, 3, 4 times till you get, if sometimes there are polypoidal and polypoidal endometrium, and you get quite a few of those with this. So this is how you do polypectomy.
So if you're doing a DNC for an incomplete miscarriage, so we don't do uterine sound and we only hold the anterior lip with the sponge holder? That's it.
Yes, it depends upon, depends if it's a recent one, then and the cervix looks soft, then you hold the anterior lip of the cervix with a sponge holding forceps, because Valsalem would be too rough an instrument and would tear it off. But if it is if it is incomplete abortion in a multiparous woman who has had some deliveries also, in that case the cervix is quite sturdy and firm, and when you look at the cervix, you know whether you can apply a Valsalem on that or not. But if you are not sure, then use a forceps which would not cause that. And of course, when you hold the anterior lip of the cervix with the sponge forceps, you hold it with not with the brute force. दांतों को किचकिचाना नहीं, जरा आराम से तसल्ली से. You have to be gentle. You see, the outcome of your surgery's result depend a lot on the respect with which you use the tissues. If you are mishandling and you are tearing things up and you are pulling and pushing, and then that all those efforts are going to damage the tissue, and the healing process will result in some fibrosis, some scarring. And therefore, when you have to go in again, you will find that you come across in so many cesarean sections, because that is the most commonly performed procedure, in which comes again and again, and there are so many patients with multiple cesarean sections. So when you open again, you find that sometimes it's not. It is the patient's own healing power and capacity, and those factors are there. But an important factor is the way the tissues are handled at that time. That also helps in quicker recovery, less pain postoperatively, and better healing, better outcomes. So the tissues must be handled with care, with respect.
Someone has mentioned that endometrial polyps start bleeding by whom?
Oh, yes, they can, but I haven't come across in my reasonably long career मेरा ख्याल है, any occasion where I had to do anything else. Yes, if it's even you see large fibroid polyps, we are not talking of endometrial polyps only, and even in fibroid polyps, what you do is that if you find that, then you continue to kind of rotate it in the sense that the pedicle gets avulsed. Usually it gets avulsed and the bleeding stops on its own. But she is right in one, or he is right in one aspect. I remember having gone through my case records in which I did polypectomy, and I learned from that in the discussion I had written that in those polyps in which the pedicle of the polyp is visible, then that should be cauterized. Cauterized to prevent recurrence of polyps, recurrence of that polyp. So that's but usually that pedicle is not visible, and in pursuit of finding that pedicle, you should not go anywhere beyond the outer part of the cervical canal. So I personally haven't come across bleeding for too long. If there is a little bit of bleeding, it subsides on its own without any major thing. और कोई सवाल? All right, Ji, thank you very much. We'll take something else next Wednesday, right?
सर अस्सलाम वालेकुम सर. फाइब्रॉइड पॉलिप को कैसे रिमूव करेंगे? उसको इनिकुलेट करके निकालेंगे अगर वो नहीं निकल
Fibroid polyp
कैसे निकालेंगे?
you're right. Sometimes fibroid polyps come down to the extent that you can see the pedicle, which is reasonably large. what we do in those is that we catch hold of the pedicle with the pedicle clamp, cut it, and then remove that and tie the pedicle. So in those cases, it is like that. But if it is inside the cervical canal or it is above that, then I would say that hysteroscopic approach is more appropriate.
Dr. Rashid.